further testimony in our case, we conclude now with closing arguments.
Well, listen, I just have a few comments. I think it's pretty clear who won this case. I and the opposing counsel are simply not arguing that the available data with prostacyclin and PAH is superior data compared to all of the PH therapies. We all agree on that, okay? The argument here is that given the significantly suboptimal morbidity and mortality associated with PH, despite upfront non-prostanoid combination therapy, i.e. ambition, even in functional class 2 patients with that 20% mortality and morbidity event in the Adani-Frost review or the analysis, the prostanoid pathway should be considered, I think strongly considered, as part of initial combination therapy despite the admitted lack of double-blind randomized control data. And remember, the title of this discussion was not that all class 1 and 2 patients, most class 1 and 2 patients should be considered. And I think that stands correct in front of us today. I think all of us can agree that if one of us was unlucky enough to be diagnosed with PAH, particularly in a high-risk subgroup such as connective tissue disease, and lucky enough to be diagnosed with early functional class 2 symptomatology, we would want the best therapy to be part of the initial treatment regimen, i.e. a prostanoid. Until we can do better in individualizing PAH therapy, I think we can all agree it is our duty to offer our patients a prostanoid as part of initial combination therapy. Thank you.
Dr. Preston, your summary argument.
Thank you, Your Honor. So let's break down again the question into functional class 1 versus functional class 2. I think I proved our point that functional class 1 patients who are usually discovered by screening and they are largely asymptomatic can benefit from less invasive, very effective non-prostanoid therapies, at least in the beginning, given the lack of clinical data and evidence-based medicine. Now, going to functional class 2 patients, the AMBITION trial, with its subsequent analysis, argues strongly against the approach of putting most patients in functional class 2 on a prostanoid from the beginning because of the success in low-risk patients of a combination therapy with a PDE5 inhibitor and the endothelin receptor antagonist. Now, we agree that in a minority of functional class 2 patients who are found to be high risk from other parameters that are included in risk calculator scores, these patients should be strongly considered to be on a prostanoid therapy in addition to the combo therapy that they usually are on. So in actuality, the minority of functional class 2 patients could benefit from a prostanoid, not a majority. And that's why because prostacyclin treatments have a whole list of side effects and disadvantages that we reviewed with our expert, we recommend screening these patients with functional class 2, and those only high risk, we think they benefit from additional prostanoid therapy. Thank you.
Thank you, counselors. Well, we've heard both sides of the argument today, and now I would just like to close with some statements. Prostacyclin therapies have great potential to an adjunct to standard combination therapy in our functional class 1 and 2 patients with pulmonary arterial hypertension. Currently, there are no consensus on which prostacyclin and which subgroups of functional class 1 and 2 patients with PAH would most benefit from this approach. Not all prostacyclin agents have the same efficacy nor the same tolerability. Not all patients with functional class 1 and functional class 2 PAH are of the same level of risk. Currently, there is insufficient evidence to determine which prostacyclin therapies and which patients with functional class 1 or 2 PAH should receive triple combination therapy with an added prostacyclin. Future studies will be needed to determine where patient risk and prostacyclin efficacy and tolerability intersect to determine which of our patients with functional class 1 and 2 PAH should be treated in this manner. Thank you. Court is adjourned.
That concludes this case of holding court in PH. Thank you for your time and interest in providing the best treatment for patients.